just to kind of make sure that we covered it all, we talked a little bit about cystography. Cystography can be done in a cysto room in surgery, or it could be a cystogram that we're doing post-trauma, like what I was talking about before. Cystography in surgery can be it can be a introduction into other exams. So I've mentioned some things. Let me bring this one up and I'll kind of draw this out. So what you'll see in some patients, it just bears a little bit of explanation, understanding, is that, again, it doesn't take just a whole lot to clog up a ureter. You've seen how small they are, right? So what we have is we've got the kidney, and then we've got the collecting system, and we've got the renal pelvis, and it goes down, makes some turns, and goes into the bladder, right? So if the patient might have a kidney stone somewhere in the ureter, they've got options. So what you'll see in surgery is they'll break up that stone either with the sound waves, like what we were talking about before, or they may use a laser. They do have a laser that they can feed all the way up into the ureter and break that stone apart. Either way, it's going to cause some trauma really to the ureter, and if it swells or another portion of that stone gets stuck, then they've really accomplished not a whole lot. So what they'll do in a lot of cases, you got bladder down here, you got urethra. What they'll do is they'll put a cystoscope up into the patient's bladder, and they'll feed a catheter. It's got a wire on it that they'll pull out, but they'll feed a catheter all the way up into the kidney, and it's got kind of a pigtail on it. And once they put it into the ureter, they'll pull that wire out, and that pigtail will manifest itself. The other end's got a pigtail on it as well. So the purpose for the pigtail is to keep the stent, that's what we refer to as a double J stent, because it kind of looks like a J on one end and it looks like a J on the other end. So they put a double J stent all the way up into the kidney to keep the ureter open so that it can pass fluid until those kidney stones, the rest of the kidney stones completely pass. So what they can use is a cystoscope or possibly a ureteroscope to go part way up. Also, though, what they can use is a basket to retrieve that. So if you saw the biliary video online, I kind of described that. And what the basket is it looks like flat wire, kind of like a cable. Cables have multiple wires going around. It kind of looks like a cable in that it's got multiple wires, thinner wires, but they're not fixed together. So what they'll do is they'll push this basket. It's on a little bitty wire. They'll push this basket up past that kidney stone, and then they'll pop open the basket. Obviously, they'll pop it open so much that it's going to damage the ureter, but they'll pop it open, and then they'll pull it back, and whenever the stone gets caught inside of it, they'll kind of collapse it back down and they'll retrieve it. So they can do that in both the urinary system and the biliary system in some cases, okay? So that's what we refer to as a basket retrieval. So SWAL, as ESWL, is breaking up with the stones. Stenting is something you'll see in surgery, and also basket retrievals as well. So retrograde pylography, they'll inject contrast all the way up into the kidneys. Renal pelvis, pylo, that's retrograde pylography. So all of those, all the way up into the kidney studies are surgical studies, but we can also do some of the cystography in radiography. So we talked about VCUG. Another thing that we don't really do anymore, but you might see it referred to somewhere, is bead chain cystography. And what they do, you know what a bead chain is. It's basically what, if you've got like a cheap key holder or a chain on a light, pull chain on light, or your fan or whatever, that's B chain. And what they would do is to take one of those, essentially sterilize it, and put it via cystoscope up into the patient's bladder, fill the bladder up with contrast, and then give that a little bit of a pull to see if there's any kind of leakage. So we don't do that anymore. That's what you call stress incontinence. We don't do that so much anymore. If a urologist is concerned with stress incontinence, in a lot of cases he'll just take a scope and go up and look. Okay, but you may see bead chain cystography mentioned somewhere. And that's what it is. VCUG we already talked about. We talked about traumatic bladders, axial bladders. You may be asked to shoot an axial bladder just to see the distal portion of the ureters, again, because they plug in the lower posterior portion of the bladder. What we're going to do is center 2 inches above the symphysis pubis, which is 2 inches below the ASIS, right? And you're going to angle your central ray 10 to 15 degrees caudad. If you do PA, you're going to do exactly the opposite. It's going to be 10 to 15 degrees cephalic. Okay? And that's AP axial. You can see that, well, 2 things it'll show you. One, it'll show you the distal portion of the bladder, maybe not at the insertion, but also if you've got a patient who's got some degree of bladder prolapse, then it will get the anterior pelvic bones off of the inferior portion of the bladder as well. Okay. But oblique of the bladder, really in context, the oblique of the IBP. Lateral bladder, you just don't see a whole lot of. Cystography. Any questions on the urinary system? Nope. Okay, then biliary system, and I think I'm going to bring that back up again and just kind of draw this out. So again, most of your biliary system questions are going to have to do with anatomy and exam type. We just don't do a whole lot of biliary stuff anymore. Ultrasound's taking that over, and it does a good enough job that we don't have to expose the patient to ionizing radiation. So what we're looking for in the biliary system, function of the kidney, function of the liver, for our purposes and what we're most interested in is formation, storage, and excretion of bile. Okay, so the most common pathology that we're going to see here is going to be biliary stones. So most common pathology that we're going to see in the renal system is going to be kidney stones, and now we're looking at biliary stones. So what we've got is the liver. Liver has 2 lobes, right? This is going to be a kind of an ugly liver. And it's divided by, there's more on the right-hand side. So this is right lobe and left lobe. And there's more on the right lobe. Let me kind of square this off a little bit. More on the right lobe than what there is in the left lobe. And it's divided by the falciform ligament. I'm just going to say falciform ligament. All right, so falciform ligament is what divides it. And what that is a fetal remnant of your umbilical cord is essentially what it is. And some people will say that, if you put something in your belly button, well, you would do this, I don't know, but if you put something in your belly button, there's still a connection there that, like in, not really prehistoric times, but like in, I don't know, biblical times, whatever, that was a way people would poison somebody else, is just put poison in the belly button and it absorbed through the falciform ligament into the liver, kill the patient dead. Whether or not that's true, I don't know. I don't know. It sounds a little hokey to me, but that there's still a connection there, maybe, I don't know. So a falciform ligament divides it into the individual lobes. And again, for our purposes, you know, there's like 1,000 different things the liver does, but we're just interested in bile creation and the storage and excretion of bile. So what you're going to have is a biliary tree in both of the lobes. They're going to be a little bit separate from each other. So you've got a left lobe, left lobe, and a right lobe. So all of the bile ducts in the left lobe are going to join up together to create the left hepatic duct. Okay? So in the same way, all the ones on the right lobe are going to join up together to create the right hepatic duct. D-U-C-T, not D-U-C-K, duct. They're going to join together to create one common duct, and we're going to call that the common hepatic duct. Okay? But that's not the end of our biliary system. What we've also got is a gallbladder is positioned also kind of behind the liver. Okay? The purpose for the gallbladder is to receive that bile and suck some of the moisture out of it to concentrate it. So the whole purpose for bile is emulsification of fat, to digest fat. And whenever you eat something that's fatty, what will happen is cholecystokinin will be released, and that will cause the gallbladder to contract and squeeze and push some of this bile out into the small intestine. So the bile has to get from the gallbladder, well, first off, the bile has to get from the liver to the gallbladder. So we've also got a duct that goes to the gallbladder. So what do we call any kind of sac? Somebody said it. Cystic duct. This is cystic duct. Okay, the whole purpose for all this is again to get bile down into the small intestine so you can emulsify that fat. So would it not stand to reason that cystic duct needs to join up to the common hepatic duct? The answer is yeah. So the common hepatic duct is actually right there. And once it joins, is right there. This patient has a very short common hepatic duct. And then it joins up to the cystic duct to form the common, what's going through it? Bile duct, exactly. Okay, so where all of these little bitty individual portions of this biliary tree come together, that's what we refer to as common bile duct. So all the fine, this is terminology on test, all the fine canals join together to create the common bile duct. Okay, so I've written over so much that I don't have a small intestine. So what we have then is they all come together and they join up with the pancreatic duct. Pancreas sits, the head of the pancreas sits right in the C loop of the duodenum, like that. So all of these ducts come together to join up with the pancreatic duct to form a bit of an enlarged area, and it's what we refer to as the ampulla of Vader. Not Darth, it's not V-A-D-E-R, it's V-A-T-E-R, Vader, okay? Ampulla of Vader. Ampulla of Vader is just where the two join up together and create a bigger duct. That's the last portion of the duct before it empties into the small intestine. We'll make kind of the small intestine right here. So this is a duodenum. The pancreatic duct, by the way, is referred to as the duct of Wierson. Okay, so ampulla Vader, duct of Wierson, you got a muscle that controls whether or not the bile comes out into the small intestine. You don't just want it spilling out all the time. So you got to have some sort of muscular control, and that is the sphincter of Odie. Sphincter Gus did it. You want to share?
No.
No? Chicken. All right. So sphincter of Oddi is just that muscle. It's where it opens up into the small intestine. Okay. The ampulovator is the broader portion where, basically you got two highways come together to make a fatter portion. Duct of Wierson, pancreatic duct. Sometimes you'll have a secondary pancreatic duct, and that's what we refer to as the duct of Santorini. Everybody's seen the pictures of Greece where stark white buildings with blue roofs, everybody wants to go, right? That's Santorini. It's the island of Santorini off the Greek coast. Okay, so just word association. Duct of Santorini is an accessory pancreatic duct. You don't always see it. And it's going to have kind of like the dual collecting system and the ureter insertion. You may have a duct of Santorini that comes off of this duct, and it usually goes above it. So it may come off of that duct and it parallels the duct of Wierson. So, you know what, I'm going to draw this as kind of a dotted line because not everybody has it, all right? Not everybody has it, and in a lot of cases it's an incidental finding. Patient doesn't even know that they have it until we do an exam that shows it, okay? And most of the time if somebody has one that comes off kind of like that, kind of again like the ureter, the patient doesn't really have any problems. The irritation comes whenever it has a separate plug-in, I think. Don't quote me on that. It's not on test, but I'm thinking whenever it has a secondary plug into the small intestine, again, you don't have a sphincter there and you can have some complications. But that is the duct of Santorini. Is the accessory pancreatic duct. So forgive the drawing. Goldie's our artist, I am not. Right? So that's the biliary system. The common exams that we're going to do for the biliary system, let me just list them here. This one's really archaic and you're probably never going to do it, and that would be an oral cholangiogram. So this used to be a common exam before my career even started. Ultrasound had already advanced to the point where it had taken this over. So oral cholangiogram, what we would do is have the patient take all kinds of laxatives. Mag citrate, you'll see these little bottles of magnesium citrate. That is like, a steroid on, or a laxative on steroids. It's going to clean you out. They may have to do cleansing enemas, limited diet, and all that kind of stuff. And the reason for that is because oral cholangiogram is a hard exam to get a good exam up. And it's for the gallbladder, and they're looking for gallstones in the cystic duct or somewhere in the biliary tree. The problem is that what you'll see when you go to surgery, whenever they remove a gallbladder, is that the cystic duct and the blood flow to and from the gallbladder are all kind of encapsulated together, okay? So what they have to do is they have to separate that out, and they have to clamp off the blood supplies and then cut a small slit. They have to isolate that cystic duct. They have to cut a small slit into the cystic duct, and they'll feed a catheter into it and inject contrast and see if the contrast goes all the way down into the small intestine. That's in surgery. That's not an oral cholangiogram. I'll point that out, though, to say this. If the patient has a gallstone and the blood supply is attached to the duct and the duct swells, then what's going to happen to the blood supply? Well, if the duct swells, it's going to press on that arterial and venous blood flow, and what's going to happen? It's going to shut it off. It's going to shut it off, right? So eventually that gallbladder is going to die, all right? But let's say it hasn't died yet. If we've got a stone and is causing that much swelling, what's the likelihood that the contrast is going to go from the liver into the gallbladder? If it's plugged up, it's not, right? So for that reason, you're probably never going to do this, but understand that you may be asked a question eventually on an oral cholangiogram, and what you have the patient do is clean out real well, take some tablets the night before that have iodine in them. The liver breaks all that down, feeds the iodine into the gallbladder, providing there is no obstruction. But what's the main thing that we're doing this exam for? Obstruction. Right. So you can kind of see why it is that ultrasound took this over, right? Because oral cholangiogram is, I'm not going to say it's useless, but it's pretty close. All right. So other exams that aren't useless would be what we refer to as a Perc. And that is a percutaneous, PCT, Transhepatic Cholangiogram. Okay, so it's Perc. We just refer to it because it's cumbersome as Perc. And what that is it's an exam that's done in special procedures or interventional. And what they do is they clean the patient off real good, and they take this long, skinny needle, and it's referred to as a Chiba needle, C-H-I-B-A, Chiba needle. And they'll stick it through the patient's abdomen, across the liver until they find a duct to inject, and then they'll look at the biliary tree and look for any kind of obstruction. Okay, that's Perc, and that's done in special procedures under sterile procedures. So unless you're working in interventional, you're probably never going to do that either. Okay, it is done still, and it's referred to as three things: either a Perc for percutaneous transhepatic cholangiogram, that's one name for it, or Chiba needle exam or skinny needle exam. Okay, so all mean the same thing. All three of those mean the same thing. So probably most common that we're going to do is operative. So in an operative cholangiogram, what we're going to do is what I've mentioned before. You're going to, most of the time it's going to be a laparoscopic operative cholangiogram, which means that they're going to take at least 3 scopes and put it inside of the patient. It's a pretty common exam. If a patient has gallstones, they just don't get over gallstones. There's no point in opening the patient up and trying to retrieve gallstones. They're just going to pull the gallbladder. Okay. Also, if a patient has any kind of bariatric surgery, any kind of weight loss surgery, they're going to take the gallstone or the gallbladder. Why? Well, you can live without a gallbladder. What does it do? Digest fat. What are you trying to not have? Fat, right. So they're going to take it. And also, if you have a patient, let's say you've got maybe a 400-pound patient loses 200 pounds, in a lot of cases they've already got stones, and just the weight loss makes those things move around a little bit, and they'll have a complication of having, a blockage. So they'll just go ahead and take it out to avoid both of those things, emulsification of fat, but also to prevent them from, having complications of stones. So what they're going to do is they're going to put these instruments inside of the patient. They're going to inflate the patient's belly. And that's kind of cool. You walk in and the patient's just got this great big distended abdomen, and they have to have a light source in there so that they can see around. And one of the coolest things is if you've got a thin patient, doesn't have a whole lot of extra padding, then the whole stomach glows. All right, so you walk into a room, the whole stomach's glowing. They've got these instruments inside, and they're going to take that blood supply off of the cystic duct, and they're going to cut a little hole into the cystic duct, and they're going to feed a catheter down inside of the cystic duct, clamp it off, inject contrast, and we have to make some images. 2 types of exams that you may have to do in surgery. The most common now is with a C-arm. So the doctor injects the contrast, and you have the C-arm. You're running the C-arm. C-arm probably has a sterile drape on it. You're running the C-arm. You're looking for the contrast. You're looking for patency of the ducts. That just means the ducts are open. So what you want to see is you want to see the contrast go from the duct, cystic duct, through the the common bile duct all the way in the small intestine. Okay. So fluoroscopy is a positive image. So what we're going to be looking for is anything that looks like a hole or a filling defect. Gallstones are non-opaque for the most part, so they don't show up on x-rays for a while. So anywhere where contrast is not indicates we've got one of two things. We either have an air bubble that was injected, which is not a big deal, it just simulates a gallstone, or we've got a gallstone. So if that filling defect moves, that's an indication that that's a bubble. If it doesn't move, that's a stone. Okay? So stones can be anywhere. They can be in the gallbladder. They can be in the cystic duct. If we get flow all the way down into the small intestine, and you don't see any kind of filling defects, then they'll take the gallbladder out. They'll sew the patient up, and the patient goes home like the next day. All right? But it's very common that if a patient has a stone, they have multiple stones. Some of those stones may be down in the common bile duct, and they can't get to it. So then they'll take, in your Merrills, there's a list of root words, the different parts of the biliary tree it refers to. The choledocoscope is a scope that they'll use for the biliary system. So they'll take the choledocoscope with that basket and try to retrieve sometimes those kidney stones. You can't do the S-wall, the shockwave lithotripsy on the gallbladder. You just can't do it. So they'll try to retrieve the stone. If they can't, then what they'll do in a lot of cases is place a tube inside of the patient. So this tube, it has an appearance like this. It's nowhere near this big, but it looks like that. So what you've got is almost like they've taken a tube, and they cut it, and they folded these two wings over. Now, what letter does that kind of look like? A T, right. So conveniently, this is one of the few things in radiology and medicine that makes sense. What do you suppose we call that? T-tube, right, it's T-tube. So in surgery, what they're going to do is they're going to put this T-tube somewhere that they have access, all right? So one of the ducts is going to go inside of one of the ducts. And then they'll inject the T-tube to make sure that it's open and it's flowing and everything's doing what it's supposed to be doing, and then they'll sew the patient up. And what that T-tube does is it sticks out of the patient, but what it does is it gives the bowel a place to go. If the bowel has a place to go and it stops pushing on that gallstone, then the swelling may go down, the stone may opt to come back out, go down the T-tube and outside of the patient's body, and the patient loses stone. Okay, so before they sew the patient up, they're going to inject this to make sure it's still open, but they're still in surgery, so it's still a operative cholangiogram, right? What we're going to do a couple of days later is we're going to do kind of a delayed cholangiogram. So what's going to happen is the patient's going to come to the x-ray department, and we're going to do what we refer to as a T-tube cholangiogram. Okay? And a T-tube cholangiogram, what we're going to do with that is we're going to take, most of the time, we're going to take some injectable contrast, ICVU, something like that, and we're going to dilute it to about half strength and inject this and look and see, it should go all the way back up into the biliary tree, and we're going to look and see if there are any stones left. And if there are no stones left, most of the time the radiologist will just pull the T-tube, let the patient heal up, hopefully the patient will heal up, and the patient will be done. Okay? So T-tube cholangiogram is done operative cholangiogram is done in surgery, regardless if we're injecting into a T-tube or not. T-tube cholangiogram is that delayed study that we're gonna do in radiology. Okay, you see the difference between the two. Technically, yes, they're both T-tube cholangiograms, but the patient hadn't left surgery yet, so it's operative, even though it's through the T-tube. The T-tube cholangiogram is gonna be what we do outside of surgery in the X-ray department. And the last one is what we refer to as, really kind of limited my space, endoscopic retrograde cholangiopancreatography. Okay, so 4 words. Retrograde, what does that mean? Going against flow, right? So retrograde, endoscopic, let's start there. Endoscopic means you're gonna use a scope. So it's with a scope, going against the flow, and we're looking for the biliary system and the pancreatic duct, okay? So this is usually done in larger hospitals in like a GI lab setting. They may have a C-arm up there for that. And what they're gonna do, or they may just have a regular fluoro table. And what they're gonna do is they're gonna put the patient under what we refer to as IV conscious sedation. So the patient's not gonna be completely out, but they're gonna have something like Versed on board. Versed is an amnesiac. Most people don't remember anything after they've had Versed, even if they're not put completely under. So they're gonna give them some sedation. They're gonna roll the patient mostly onto their stomach, and then they're gonna numb their throat, and they're gonna feed this tube all the way down into their stomach, through their stomach, into the small intestine, and then, so you've got this great big tube, and then they'll take and they'll put a catheter right into the sphincter of Oddi. Inject contrast retrograde to look for stones, or sometimes if the stone is known to be right here at the sphincter of Oddi, what they'll do is they'll put a little bit of a cut into the sphincter of Oddi, and sometimes that stone will just plop right out. Okay, so that's ERCP, endoscopic retrograde cholangiopancreatography. You'll probably do, put it up here, ERCP, you probably do that, might do that if you go to surgery. If you happen to find yourself in a interventional suite, you may do a Perc, probably never do an oral. Okay? So really all we're looking for is patency of the ducts. Are the ducts open? Can the bile get into the small intestine? All iodinated contrast. Just how you might get to it. Any questions?